Hey there, fifth-year med students, and welcome to this high-yield explainer. Look, I know you are all gearing up for your pharmacology board exams right now. And let's be real, if there is one topic that consistently trips people up, it's the neurobiology of addiction. It's complex, it's incredibly testable, and it literally bridges the gap between microscopic neuroscience and macroscopic clinical behavior. So today, think of me as your personal tutor. We're going to take Professor Lovio Luongo's precise pharmacology notes and distill them right down into a structured visual format you can just lock into your memory. Trust me, by the end of this, you'll be totally ready to ace whatever questions they throw your way. Let's get right into it. Okay, here is our highly structured syllabus for today's explainer. We'll start by clearing up those confusing, often overlapping clinical definitions. Then we'll map out the precise microscopic neurobiology of the mesolimbic reward pathway. After that, we'll look at exactly how drugs alter this system, followed by the clinical and exam implications. And finally, we'll wrap up by reviewing the absolute core concepts you need to memorize. All right, let's dive into Section 1, Core Definitions in Pharmacology. To really get this, we have to view substance use disorder as a biopsychosocial disease, one that depends heavily on genetics, the environment, and of course the drug itself. Okay, so dependence. This is a massive exam trap, guys. Students so often equate dependence purely with substances of abuse. But actually, scratch that. That's totally incorrect. Dependence is simply a state where your body functions normally only in the presence of a drug. A classic example straight from Professor Luongo's notes: benzodiazepines. Now, benzos lack a primary addictive aspect in this context, but when taken long-term to treat something like insomnia, the patient literally cannot fall asleep without them. Their body has grown to depend on it. If you abruptly interrupt the drug, boom, you get physical disturbances and withdrawal. And that is exactly why, clinically, we absolutely have to taper these medications instead of stopping them cold turkey. Next up is tolerance. This is a state where the body just stops responding to a specific dosage of a drug. So you have to continuously bump up the dose just to get that exact same initial effect. Now, obviously, tolerance is super common in abuse drugs like opioids, but it happens with everyday normal medications too. A really prime example you want to remember for your boards is salbutamol, used for acute asthma attacks. Over time, patients can build up a tolerance to it, meaning they need more of the drug just to open their airways. Now, watch out because examiners absolutely love this trick. Okay, so opioids and benzodiazepines clearly display tolerance over time, but substances like cocaine and alcohol, they don't readily display this same classic tolerance. Professor Luongo makes a point to highlight that for substances like cocaine and alcohol, low doses create the same effect as high doses, and interestingly, that effect doesn't really change over time like it does with an opioid. Make sure you highlight that distinction in your brain. And that brings us to addiction, or substance use disorder. Addiction is considered a serious mental illness. It's a chronic, relapsing brain disorder characterized by a total loss of control and compulsive drug-seeking behavior, despite all the harmful effects. The real key differentiator here is asking why the drug is taken. In addiction, the substance isn't taken for the body's survival. It's not treating a specific ailment. It's taken purely for the highly pleasurable, rewarding behavioral reinforcement. We call that positive reinforcement. Real quick, when we classify these drugs by preparation source, a key category is semi-synthetic drugs. These are synthetic derivations created from a natural source. And this brilliantly illustrates a super high-yield example you just have to know: heroin. Heroin is actually synthesized in just one single chemical step directly from natural morphine. All right, another critical classification to cover is hormetic substances. These drugs have what we call a biphasic effect. Basically, they do one thing at a low dose and something completely different at a high dose. You absolutely must memorize these shifting symptoms. Take alcohol. At a low dose, it acts as a stimulant with some initial euphoria, but crank up the dose, it completely flips and enters a depressive phase. Cannabis is exactly the same story. Low doses give you relaxation and a slowed heart rate or bradycardia, but push it to a high dose, and suddenly the patient presents with a rapid heart rate, tachycardia, intense anxiety, and maybe even hallucinations. Moving right along to Section 2, the mesolimbic reward pathway. If you want to really understand addiction, you have to understand the wiring. You've got to meticulously map out the specific dopaminergic circuit these drugs are hijacking. The mesolimbic pathway, or the reward pathway, goes like this. Step 1. It originates in the ventral tegmental area, or VTA. Step 2. Those dopaminergic neurons project forward to the ventral striatum, specifically hitting a highly testable structure called the nucleus accumbens. Step 3. The whole rewarding process continues with projections from the nucleus accumbens all the way up to the prefrontal cortex. So VTA to nucleus accumbens to prefrontal cortex. Drill that exact anatomical flow into your head. So what's actually happening when dopamine hits that middle step, the nucleus accumbens? Well, it regulates something known as incentive salience. That's basically just your motivation and desire for rewarding stimuli. It facilitates reinforcement and increases pleasure. And evolutionarily speaking, this is pure survival. The system was designed to make natural rewards like food, water, sex, and nurturing feel good. It's exactly why chugging a glass of water when you're incredibly thirsty or eating after a long fast feels so intensely pleasurable. Your mesolimbic pathway is literally rewarding you for staying alive. Let's move to Section 3, Mechanisms of Drug Alteration, and see how this builds. So what happens when highly potent exogenous drugs crash this delicate ancient survival party? Well, the short answer is they aggressively hijack the system. Addictive drugs like cocaine, alcohol, and nicotine artificially surge extracellular levels of dopamine, preferentially right there in the nucleus accumbens. And we know this for sure. It's been proven via microdialysis in rodents, where scientists literally measure the dopamine spikes after injecting morphine, nicotine, and ethanol. And get this, because it's a shared mammalian pathway, we aren't the only ones susceptible. Rats will get addicted to cocaine-laced water. Cats actively seek out a high from catnip. There are even dolphins out there that have been observed purposely playing with toxic pufferfish just to get intoxicated. It's wild. So, bringing this microscopic biology right back to our macroscopic clinical definitions, that massive artificial dopamine surge creates an intense positive reinforcement. The brain literally cannot ignore it. But, the brain is smart. It creeps homeostasis. So with continuous drug exposure, it's forced to adapt to this flood of dopamine by downregulating its own receptors. When that happens, the patient suddenly needs more of the drug just to get the same initial high. Bam, that's tolerance. And eventually, they need the drug just to maintain a brand new artificial baseline of normal. And that, right there, is dependence. All right, let's get serious. Section 4, Clinical and Exam Implications. I need you to really listen up here, because this section is basically your ultimate exam cheat sheet for your pharmacology boards. If you're sitting in your oral boards or staring down an essay prompt, how do you perfectly structure an answer on the neurobiology of addiction? You can't just word vomit buzzwords. You need a cohesive, locked-in narrative. To get top marks, your answer must explicitly bridge the gap. Start with the patient's clinical presentation. The behavioral compulsion, the loss of control, that's the addiction. Then trace that behavior directly to the precise anatomical projections, the dopaminergic neurons firing from the VTA straight to the nucleus accumbens. Finally, lay out the pharmacology. The exogenous drug is artificially hijacking extracellular dopamine in that ventral striatum, completely rewiring the brain's reward learning. Now, what if the examiner asks you to explain withdrawal mechanically? Here's your answer. So the crucial point is that withdrawal represents a severe neurological crash. It's the direct physical consequence of pulling the external drug stimulus away from a dependent patient. The body downregulated its natural systems to adapt to the drug, right? So when you suddenly remove it, the brain is left stranded way below baseline, triggering intense physical disturbances. And this perfectly explains why relapse is such a massive clinical hurdle. Addiction permanently, physically alters the mesolimbic pathway. Because of this neurobiological rewiring, relapse is a core expected feature. It's classified as a chronic relapsing brain disorder, not a temporary acute illness like a bacterial infection you just cure and forget about. Grasping this is absolutely vital, not just for your exams, but for your long-term disease management and having empathy for your patients. Almost done. Section 5, Reviewing the Core Concepts. Okay, to make absolutely sure you walk out of this explainer ready to dominate your exam, let's rapid-fire summarize everything we've discussed into the 15 absolute most essential sentences. 1. Substance use disorder is a biopsychosocial disease. 2. Addiction is a chronic relapsing brain disorder. 3. Compulsion is driven by positive reinforcement. 4. Tolerance means the body stops responding, requiring dosage increases. 5. Dependence means needing the drug just to function normally. 6. Abrupt stopping in a dependent state causes physical withdrawal. And 7. All of these clinical signs are rooted in the mesocortical limbic circuit. Keep that momentum going. 8. The anatomical flow is VTA to nucleus accumbens to prefrontal cortex. 9. Dopamine in the nucleus accumbens regulates incentive salience and motivation. 10. Addictive drugs artificially surge that dopamine. 11. The brain's attempt to adapt to this surge causes tolerance. 12. Reliance on that new artificial baseline establishes dependence. 13. Withdrawal is the severe neurological crash when that baseline is removed. 14. This entire process transforms a voluntary choice into a compulsive biological need. And 15. Understanding this exact neurobiology is the essential link for proper clinical diagnosis and management. Now, what's really interesting to think about as we wrap up is this. If addictive substances fundamentally hijack our most ancient, hardwired survival circuits, literally tricking the brain into believing it needs a chemical surge just to survive, how can modern medicine possibly hope to rewire that circuitry? It's a massive, staggering question. But mastering the pharmacology we reviewed today is the very first step toward finding that answer. Thank you so much for studying with us on this explainer. Keep reviewing those notes and go ace those pharmacology board exams.